Everyone, am I audible and visible to everyone? So this is about Unacademy. In the Plus subscription, you are getting access to both live and recorded classes, and you can study on the device of your choice. You can learn from India's top educator, and you have access to more than 25,000 of questions. In the academic subscription, you are getting both of Unacademy as well as Prep Ladder. And these are the feature of special classes, which we have already told you that there will be interactive live classes. You can raise your hand, you can never miss a class, you can get lecture notes, you can download after the class the PDF. And there's a new feature which is going on, that you can raise your hand if you want to say something in that condition. And there are updated and highly effective question bank, more than 25,000 questions. They are high yield clinical question based on the latest pattern of the next. And we are proud of our star learners. You can see the top rankers, and there are more two batch course which will start. One is Focus FMG batch, other is Target Next 22 batch. This is a NEET PG 1 month package, and for all those packages you can apply the code Physio10. The code you can apply is Physio10. Let me tell you, for the maximum discount you can just put the code Physio10 for 10% discount, whatever is available there. Now let me, without wasting time, let me further start our discussion for NEET PG. It's very crucial time for you people, so I will not waste any time. So starting with question number 1, just be very focused and tell me what is the answer. A 45-year-old man present to emergency department with complaint of dizziness, nausea for past hour. He says he can feel his heartbeat racing. Okay, palpitation is there. He also reports of the generalized weakness that begin in the morning. He was diagnosed with the end stage renal disease 2 years ago and currently on diagnosis and dialysis, but he missed his last dialysis session. He has been diabetic also for 15 years, does not smoke and all. Okay, ECG is ordered, who is showed peaked and T wave with prolongation of PR interval. What is this? Peaked and narrow T wave with prolongation of PR interval. What is this? Yes, you can comment on the chat box. There is a peaked and narrow T wave with the prolongation of PR interval. It is, of course, you know that hyperkalemia. Yes or no? In hyperkalemia you have tall tented T wave, or you can say peak and narrow T wave. So in hyperkalemia, and also you can see the lab parameter potassium is high. In the lab parameter also potassium is high. So what is the mechanism of action of the most likely treatment? What is the first drug which you want to give in hyperkalemia? Whatever may be the cause, diabetic, hypertensive, whatever, CKD, whenever there is hyperkalemia, what should be the first drug of choice? Whenever there is hyperkalemia, what should be the first drug of choice? Then we will discuss the mechanism of action of that drug. Sodium bicarbonate. Why you want to give sodium bicarbonate? You can give, of course, because of hypokalemic metabolic alkalosis and all those things you can. What is the first? First is always calcium gluconate. Can you tell me why you want to give calcium? After that you can give insulin so that potassium can go inside the cell. After that you can give insulin. Insulin cause influx of potassium inside the cell. But the first drug is always the calcium. So what is mechanism of action of the drug which you want to give in hyperkalemia? Why you want to give calcium in hyperkalemia? It blocks sodium potassium pump. it antagonizes the membrane action of hyperkalemia, it blocks beta receptor, it prevents platelet aggregation, or it increases potassium loss. Why you want to give calcium as the first drug of choice? It was recently asked in UAPSC also, that we know this. What is the answer of this question? Because calcium stabilizes the membrane. How? How calcium stabilizes the membrane? Because voltage gated sodium channels are surrounded by the calcium, so it will prevent sodium influx, because both are cation. So by this, calcium is stabilizing the membrane. And if there is less calcium, more sodium will go, more will be the action potential, more will be the muscle contraction. So that is why calcium is always needed. That is why when there is hypocalcemia, it is called as tetany. It is called as tetany. You get two signs positive. One is called as Chostek sign. Other is called as Trousis sign. In Trousis sign, if you produce ischemia by the BP cuff, then you can get carpopedal spasm. This is called as carpopedal spasm. So you get carpopedal spasm when you create ischemia. It is called as Trousis sign. What is Chostek sign? If you tap facial nerve, there will be facial muscle contraction. So calcium is very important for stabilizing the membrane. And in hyperkalemia, RMP get very close to the threshold. So there will be lot of influx of sodium. You want to prevent the influx of sodium. And to prevent influx of the sodium, you need to stabilize the membrane more. Otherwise, there will be, your heart will stop. The heart of the patient will stop if there is hyperkalemia. That is why first is to give calcium so that membrane can be stabilized. Second, you can give insulin, because insulin causes potassium inside the cell. It will decrease the blood potassium level. It will decrease hyperkalemia. Then you can give fluid and all, but the first is always calcium. So why? Because it antagonizes the membrane action of hyperkalemia. It stabilizes the membrane. So due to, in this condition, it was CKD, diabetic kidney disease, but the main concern over here is hyperkalemia. The main concern which you can see here is hyperkalemia. And always remember, this is a question which have to come in your exam in somehow or the other. Either they will ask you hypocalcemia, or they will ask you hyperkalemia, or they will ask you tetany, or they will ask you Trousis sign. Some or the other, this topic is very important. So in hyperkalemia, you have to give calcium and insulin. Now next question. Just read it fast. A 57-year-old man present to urgent care clinic with 1 week history of diffuse bone pain, generalized weakness, diagnosed with the end stage renal disease. Again, CKD. Currently on dialysis and diffuse bone tenderness. X-ray of the leg reveal osteopenia and osseous resorption. The final step of activation of the deficient vitamin in this patient occur by which of the following enzyme? In CKD patient, you always give calcitriol, vitamin D3. CKD patient is always supplemented by vitamin D3 calcitriol. Why? What is the reason that you want to give vitamin D3 to CKD patient? Because the step which is required for the activation of vitamin D3 is which one? 7-alpha hydroxylase, alpha hydroxylase, L-antitrypsin, alpha glucosidase, or 24-25 hydroxylase. Which step is important for formation of calcitriol in the kidney? Which step is important for formation of calcitriol in the kidney? See, in the answer is alpha hydroxylase. I will tell you why. See, in the skin, you have 7-dehydrocholesterol, and when ultraviolet rays falls on the skin, 7-dehydrocholesterol is converted into cholecalciferol. Then it goes in the liver and undergo 25 hydroxylation. It forms 25 hydroxy cholecalciferol. Then it goes to the kidney, and there you need 1 alpha hydroxylase or alpha hydroxylase and parathormone to form 125 dihydroxy cholecalciferol. So either there is hypoparathyroidism or kidney disease. Calcitriol will not be formed because 25 hydroxy cholecalciferol is converted into 125 dihydroxy cholecalciferol into the kidney under the presence of 1 alpha hydroxylase. Okay, so that it can form into 125 dihydroxy cholecalciferol. So in the CKD patient, why there is osteopenia? Because there is no vitamin D3 formation. Vitamin D3 formation need involvement of the kidney, involvement of the alpha hydroxylase. So in CKD patient, you need to give calcitriol because of deficient of alpha hydroxylase enzyme working in the kidney. Am I clear? Is this point clear to you? Okay. So the next question. See, whenever you get a long question, always read the last sentence. If question is clear with the last sentence, it is okay. If it is not clear, then you have to read the whole question. See, he is most concerned about the urine color and the volume. Urine is visibly yellow. So which segment of the nephron is primarily responsible for these changes? Which segment of the nephron is primarily responsible for these changes? Yes, please. If someone is going somewhere else and urine is visibly yellow, low in volume, he is returned from the trip of South America, but he is concerned about the urine. So someone is complaining about the urine color. So which segment of the nephron is primarily responsible for these changes? Glomerulus, PCT, PST, loop of Henle, or the distal tubule? What is the answer? Sujit Kumar, PCT. Neelam, Tuba. What is your answer? Loop of Henle. Loop of Henle. So you know that if this is your glomerulus, suppose that, let me tell you, if this is your nephron, what is the normal GFR? Normal GFR is 125 ml per minute. Urine is 1 ml per minute. Meaning by what? Meaning by more than 99% is reabsorbed. More than 99% of water is reabsorbed in this portion. And the reabsorption of more than 99% is because of a mechanism called as counter current mechanism. It is because of counter current mechanism which is happening in the loop of Henle. So there are two different questions. Who is creating counter current mechanism and who is maintaining? See, water can only be reabsorbed if your medulla is hyperosmolar or hypoosmolar. Water can be reabsorbed more than 99% only if your medulla is hypoosmolar or hyperosmolar. What do you think? Medulla is hyperosmolar, isn't it? If you want to reabsorb more than 99% of water, it means medulla is hyperosmolar. So who is creating medullary hyperosmolarity and who is maintaining medullary hyperosmolarity? Who is creating medullary hyperosmolarity and who is maintaining medullary hyperosmolarity? So answer here will be counter current multiplier, and here answer will be counter current exchanger. So medullary osmolarity is very, very important because you want to reabsorb the water. Okay, that is why urine can be yellow or white, whatever be the reason, but here you can see in this patient urine is visibly yellow. So which segment of the nephron is responsible for this change? Answer is loop of Henle, because of counter current multiplier and exchanger which is happening in the loop of Henle. So answer will be loop of Henle, not PCT. Don't think that maximum water absorption is PCT, so answer will be PCT. No, concept here is medullary hyperosmolarity is created by counter current multiplier in the loop of Henle. This is the answer. So next question. What is the diagnosis of this clinical feature? First of all, tell me the diagnosis, then I will ask you the question. Read this question till here. A 56-year-old man present to emergency department for shortness of breath for last 2 hours. Despite his diagnosis of heart failure 2 years ago, he refused to make any diet change. He take aspirin, carvedilol, but is poorly compliant. Vital sign: pulse is high, respiration is high, BP is high, visibly distressed, unable to lie down. He is taking shallow breath and auscultation reveal bilateral crackle in the chest. What is this? Jugular venous distension, pitting edema in the lower limb. So what is this? What is the answer of this question? Anyone? Yes, congestive heart failure, of course, and you can see pulmonary edema also. Bilateral crackle is there because of the back pressure, back flow. There is pulmonary edema also. Right heart failure, yes. So what you want to give to the patient if there is having pulmonary edema? So which of the mechanism of action of the drug can relieve his ongoing symptom? Now come to the point. Which drug you want to give? The mechanism of action of that drug. Yes, biventricular failure, very good. The most common cause of right ventricular failure is left ventricular failure. The most common cause of right ventricular failure is left ventricular failure. So yes, diuretic. Which diuretic you want to give? Which is the drug of choice of pulmonary edema? Loop diuretic. Very good. Loop diuretic you want to give furosemide, ethacranic acid or torsemide. So what is mechanism of action of loop diuretic in this question? What is the mechanism of action of loop diuretic in this question? Acting on the beta receptor to increase cardiac contractility by holding the water or blocking NKCC. Yes, you want to give Lasix. It lasts for 6. So it is called as Lasix, diuretic, furosemide. Yes, very good. Number C. Blocking NKCC co-transmitter in TAL. Wonderful. So this is TAL, thick ascending loop of Henle. Yes, Duda, Teza, C, Shivam Singh, NKCC. So yes, NKCC. Very good. So furosemide is acting on this channel, and the mutation of this channel is called as Bartter syndrome. You will get salt wasting, you will get polyuria, you will get secondary hyperaldosteronism. Okay, you will get hypokalemia, you will get metabolic alkalosis, you will get renal stone nephrolithiasis. These are the characteristic symptoms of the Bartter syndrome, and furosemide can be given so that it can block NKCC pump. And if you block NKCC pump, you are hampering what? You are hampering counter current multiplier, because NKCC is the most important for counter current multiplier. So if you block NKCC, water will not be reabsorbed. It will act as a wonderful diuretic, and this edema will subside, and our right ventricular, left ventricular, pulmonary edema all will be subsided. So now next question. Okay, a 10-year-old boy is brought to a pediatric clinic by his parent with the pain and the weakness in the lower extremity for past 3 weeks. So 10-year boy is going to the doctor with pain and weakness for past 3 weeks. The patient mother says that he has been active until weakness and the pain started during the social practice. He says he also experienced muscle cramp, especially at night. His mother adds that patient constantly wake up to urinate night. Polyuria is there, you can say polyuria is there. Patient denies any recent trauma and all those things. In the lab, see the lab finding and tell me the diagnosis. Just read the laboratory finding and tell me the diagnosis. You can get hypokalemia. Okay, I will not give a hint. Just read of your own and tell me the diagnosis. After seeing all these lab parameter, serum potassium, serum magnesium, pH, metabolic alkalosis, bicarbonate. So now, what is your diagnosis? Fanconi syndrome, Gentleman syndrome, Barder, Little or Cone? You want to look for once again? You can see this. Shivam, Gentleman, Duda, Barter. Okay. It is Fanconi, it is Barter, is it Gentleman? Is it Little? Gentleman, good. Barter. See, Barter, the most important characteristic of Barter is nephrolithiasis. Can anyone tell me what is the most important clinical feature of Gentleman? What is the most important characteristic of Gentleman? With the lab we can go to that, but can you tell me the most important clinical complaint? Patient will tell you. Tetany. Tetany is the characteristic of Gentleman. Nephrolithiasis is of the Barter. Even if you forget everything, at least you can say that nephrolithiasis, because of the increased clearance of the calcium from the urine. So you can see muscle cramp. Even if you don't have lab parameter, you can come to the diagnosis. So here you can see hypokalemia, hypomagnesemia, the most important characteristic. See, hypokalemia, polyuria, metabolic alkalosis, this is common in both Barter and Gentleman. But Gentleman has the most important characteristic of hypomagnesemia, which will give you symptom of tetany. Barter syndrome has most important characteristic of increased calcium clearance in the urine, having nephrolithiasis, renal stone. So this is a very characteristic of, you can say, Gentleman syndrome. So Barter is because of NKCC pump mutation, Gentleman is because of sodium chloride mutation, and calcium reabsorption is more. It mimic like which diuretic? Gentleman mimic like thiazide, and this mimic like loop diuretic, isn't it? Loop diuretic. Now, which diuretic you can give in nephrolithiasis and why? If a child is coming to you with a recurrent nephrolithiasis because of the Barter syndrome, which diuretic can be used? Yes, very good, Shivam, thiazide. Because thiazide increases calcium reabsorption. It prevents the excessive clearance of calcium from the urine. It will prevent excessive clearance of calcium from the urine. So thiazides can be given whenever there is chances of recurrent nephrolithiasis. Okay. What about Fanconi syndrome? It is renal tubular acidosis type 1 or type 2. Is it renal tubular acidosis type 1 or type 2? Proximal segment is involved or distal segment is involved? Anyone? It is type 2. Proximal, you cannot absorb bicarbonate. You cannot absorb bicarbonate, causing metabolic alkalosis, hypokalemic, this metabolic acidosis because of loss of bicarbonate. What about Liddle syndrome? Liddle syndrome, there is gain of mutation of ENaC. It is also called as pseudo hyperaldosteronism. It is also called as pseudo hyperaldosteronism. Cone syndrome is hyperaldosteronism. How to differentiate between Liddle and cone? Both will present to you with hypertension, increased sodium absorption, but how to differentiate between Liddle and the cone syndrome? Yes, Shivam. Yes, aldosterone is normal in the Liddle syndrome. In the cone syndrome, aldosterone is high. Aldosterone is normal in Liddle syndrome. That is why it is called as pseudo hyperaldosteronism. Yes, renin will be disturbed in both. So by renin you cannot differentiate, but by aldosterone. And what is the drug of choice for Liddle? What drug you will use in Liddle syndrome? There is gain of mutation of ENaC. So drug of choice will be ENaC blocker, amiloride. And cone syndrome, there is excessive aldosterone. So you can give aldosterone antagonist, that is spironolactone. You can give spironolactone. In Fanconi, you know it is RTA type 2. I will discuss in some other question. But this is RTA type 2. Proximal tubular defect. Okay, coming to the next question. A 68-year-old man present to clinic for regular health checkup, hypertensive diagnosed with CHF, having hyperlipidemia, does not take any medication. Hypertensive medications are there. So BP is 150 by 98, 160. Now doctor decide to add indapamide. What is indapamide? Which drug is indapamide? It is loop diuretic, it is thiazide, it is thiazide-like diuretic, it is aldosterone antagonist, or what? Indapamide is which variety of drug? Which variety of drug is indapamide? Tell me please. It is thiazide, not thiazide. It is thiazide-like diuretic. It is called as thiazide-like diuretic. Okay. So indapamide is added. The patient is compliant with the medication. He comes back to the physician. Just 1 week after using indapamide, he is having muscle cramping and weakness. So which of the following can be the cause of this indapamide drug? Why patient is having this muscle cramping and all after using indapamide? Indapamide is just like thiazide, so called as thiazide-like diuretic. So I just discussed all the clinical feature. Yes, very good, Shivam. Hypokalemia. Hypokalemia is the answer. Hypokalemia. Good. So the next question will be what? I know I am fast, but because your exam is tomorrow only, so I have to be fast. Just tell me. A 64-year-old man present to emergency department with nausea, vomiting and all past 24 hours. He further adds he is significantly aware of the heartbeat, diagnosed with type 2 diabetes mellitus for 20 years. Diabetic person for 20 years, hypertensive for 15 years, taking metformin and captopril, ACE inhibitor. He occasionally take naproxen. Excuse me. He occasionally take naproxen for the knee pain and SID is given. He does not smoke but drink alcohol occasionally. Father, sister have diabetes. Temperature is there. BP is a bit high. Regular pulse. Okay. ECG is ordered and shows peak T wave. Peak T wave means what? Hyperkalemia. So one point we have noted till now. Hyperkalemia. Diabetic person, hypertensive person, knee pain is there and SID is taking. Hyperkalemia number 1. Now it is also given in this. After seeing this lab, forget about the option, just tell me your diagnosis. After seeing this lab parameter, just forget about the option, tell me first diagnosis, then we will come to physiology. What is the diagnosis of the question? See, at least 2 or 3 questions will come on the same topic definitely this year. After this question I will discuss that point, but before that tell me your diagnosis. Yes, Shivam, RTA which 1, 2, 3, 1, 2 or 4? How to approach a case of, okay, before RTA tell me which electrolyte abnormality it is. Metabolic acidosis, alkalosis, high anion gap, normal anion gap, or whatever. Yes, Siddhant, 4. Okay, you telling RTA type, okay. Before coming to diagnosis, tell me which electrolyte abnormality it is. Which electrolyte abnormality? 7.32. It is acidosis. Bicarbonate is low. It is metabolic. So first point to be noted here is that it is metabolic acidosis. And I have told you so many times, never use this word metabolic acidosis. Always you have to tell me normal anion gap or high anion gap. Whenever metabolic acidosis you are uttering this word, always tell me, is it normal anion gap or it is high anion gap? Please tell me. Yes, Siddhant, it is high anion gap. So how you calculate anion gap? Sodium plus potassium minus bicarbonate plus chloride. So how much it is coming? 8 to 16 is normal, it is 15, I think 15.5. So according to me, I think it is normal anion gap, but you can calculate of your own. Sodium plus potassium minus chloride plus bicarbonate, how much it is coming? Till 16 it is okay, it is 50, I think it is 15.5. Yes, Siddhant Gupta, please calculate. Anion gap can be calculated by, okay, I have to do for you. Minus 107 plus, how much it is? 19. Okay. 141.5 minus 126. 15.5, it is normal anion gap. 15.5, not 19. So I'm saying it is 15.5. So 9, it is normal anion gap, metabolic acidosis, and there are two main causes of normal anion gap metabolic acidosis. What are the two important causes of normal anion gap metabolic acidosis? One is diarrhea, other is RTA. How to differentiate between diarrhea and RTA? How to differentiate between diarrhea and RTA? पहली बात तो डायरिया का कोई सिम्टम नहीं दिया हुआ है, एंड सेकेंड थिंग इज बाय यूरिनरी एनायन गैप. इन डायरिया यूरिनरी एनायन गैप इज लेस देन 0. इन आरटीए यूरिनरी एनायन गैप इज मोर देन 0. सो व्हाट इज इट इज, डायरिया और आरटीए? अकॉर्डिंग टू यूरिनरी एनायन गैप इट इज डायरिया और इट इज आरटीए. DKA is not normal anion gap. DKA comes in high anion gap. Do you know the mnemonic mud piles? Methanol, uremia, diabetic ketoacidosis. You know mud piles is the mnemonic for high anion gap. Mud piles is the mnemonic for high anion gap. But it is normal anion gap having diarrhea or RTA. How to differentiate between diarrhea and RTA? By urinary anion gap. If urinary anion gap is less than 0, it is diarrhea. If it is more than 0, it is RTA. इसमें क्या होगा? It is 20. It is RTA. So this is not definite, it is RTA. Okay, now coming to the next page. So RTA is of three type. Now RTA can be of three type: type 1 RTA, type 2 RTA, type 4 RTA. Type 1 is because of what? DCT. Okay. Type 2 is because of what? PCT. In type 1 there is defective acidification of urine. There is defective acidification of urine. In type 2 there is defective bicarbonate absorption. Type 4 is due to hypoaldosteronism. Now tell me, if you cannot acidify the urine, acid will be in the blood causing metabolic acidosis because of the kidney. So if there is defective acidification of the urine, okay, it is metabolic acidosis due to kidney cause. It is called as RTA type 1. RTA type 1. And if you cannot absorb bicarbonate, you are losing the base. If you lose the base, there will be metabolic acidosis. It is called as RTA type 2. In type 4, there is decreased aldosterone. Whenever there is less aldosterone, there is what? More secretion of potassium is by aldosterone. But if there is less aldosterone, potassium will be more in the blood. That will cause hyperkalemia. And hyperkalemia is compensated by metabolic acidosis. So all these three are metabolic acidosis due to kidney. If there is defective acidification of the urine, you are not acidifying the urine. You are not throwing acid in the urine. You are not throwing acid in the urine. So acid will be in the blood. So that will create metabolic acidosis type 1. And if you are not reabsorbing the base, it will again cause metabolic acidosis due to defective bicarbonate absorption. It is called as RTA type 2. If there is decreased aldosterone, okay, you cannot through potassium. The main function of aldosterone is to secrete the potassium. So potassium will be high in the blood, causing hyperkalemia. So metabolic acidosis due to hyperkalemia. So all these are ultimately causing metabolic acidosis. But which is the only metabolic acidosis having hyperkalemia? It is RTA type 4. In this particular question, already you know there is a hyperkalemia because of the ECG finding. So now, what is your final diagnosis? What is your final diagnosis? RTA type 1, 2 or 4? Yes, in ECG there is tall peak tented T wave. So hyperkalemia is there. So what is the final diagnosis? Final diagnosis is RTA type 4. So what is the mechanism of, what is the pathophysiology of RTA type 4? What is the pathophysiology of RTA type 4? RTA type 4 की pathophysiology क्या है? Yes, very good. Decrease aldosterone secretion. Decrease aldosterone secretion. Hypoaldosteronism. Okay. Is this point clear to everyone? Now, why increase ketogenesis? This will be high anion gap. Impaired distal tubular acidification. What is this RTA? Which type of RTA it is? Impaired distal tubular acidification. Which type of RTA it is? किस तरीके की RTA है? RTA. Which type of RTA it is? RTA type 1. Decrease bicarbonate reabsorption in the proximal tubule. What is this RTA? RTA type 2. Metformin overdose. This will be of course high anion gap, metabolic acidosis. This can be high anion gap metabolic acidosis. So how to approach a case of metabolic acidosis? We have discussed just now. How to approach case of metabolic acidosis? Whenever you are getting a case of metabolic acidosis, either it can be normal anion gap. First of all, calculate anion gap. Either it can be normal anion gap or it can be increased anion gap. In increased anion gap, you have mnemonic of mud piles. Examples are mud piles. I will tell you. In normal anion gap, there are mainly two examples. There are more than two examples like hypersegmentation and all, but mainly either you have diarrhea or you have RTA. How to differentiate between diarrhea and RTA? In diarrhea, urinary anion gap will be how much? If you don't take potassium value, then range will be different. There are both formula are in use. If you don't take potassium in the value, then range will be different. If you take potassium, then the range will be different. Okay. In RTA, it is urinary anion gap is more than 0. Thanks, Shivam. So urinary anion gap, if it is less than 0, it is diarrhea. If it is more than 0, it is RTA. Now RTA can be of three types: RTA 1, RTA 2, RTA 3, 4. RTA 1 is what? Defect in DCT. RTA 2 is defect in PCT. RTA 4 is hypoaldosteronism. So this is how to approach a case of metabolic acidosis. And what are the mud piles? Mud piles are M for methanol, U for uremia, renal failure, D for DKA, diabetic ketoacidosis, P for paraldehyde. Okay, mud piles. I for isopropyl alcohol, iron, ibuprofen, indomethacin, L for lactic acidosis, then ethylene glycol, then salicylate, mud piles. And normal anion gap, the common examples are diarrhea and RTA. They are common. Other can be hyperalimentation, acetazolamide, fistula, pancreaticoduodenal fistula. So these can be normal. Now, this you can, if urinary anion gap is 0, it is diarrhea. If it is more than 0, it is positive. Three types of RTA are there, which we have discussed. In type 1 or distal RTA, there is defective acidification. So acid will be not thrown in the urine. So urine pH will be acidic or alkaline. Tell me that. If acid is not thrown in the urine, and that is why there is metabolic acidosis. So pH of urine will be a bit alkaline, isn't it? It is non-specific, but here you have acidic, and the potassium level is hyperkalemia only in type 4 RTA. So if you know this point, you can differentiate between type 1, type 2 and type 4. Okay? And these are the different cause which you must remember. What are the diseases that can cause distal RTA? What are the diseases that can cause distal RTA? Defective acidification of the urine, like autoimmune disease, Sjogren's syndrome, primary biliary cirrhosis, SLE, rheumatoid arthritis. There are few drugs that can cause distal RTA, type 1 RTA, amphotericin B and lithium. There are few diseases that can create hypercalciuric condition, like vitamin D intoxication, like sarcoidosis. So you must remember all causes. See, approach a case of metabolic acidosis, then you have to reach the diagnosis. After making the diagnosis, you must also know what are the diseases that can cause particular type of RTA. Type 2 RTA can be idiopathic. It can be acquired because of carbonic anhydrase inhibitor. If phosphamide, aminoglycoside, there are few chemicals like copper, lead, mercury, multiple myeloma, light chain disease, PNH. So this should be on your reflexes before going to your examination. What are the disease that can cause proximal RTA or type 2 RTA? Okay. Now tell me fast. A 74-year-old man visit to the clinic for a routine health checkup. He has been hypertensive for past 20 years, has CHF for past 2 years. He is currently on capropil and claims to be compliant with the medication. His most recent echo shows his ejection fraction has decreased. So the physician decided to add spironolactone. If you are using spironolactone, which of the following complications should be closely monitored? Whenever you are giving a patient spironolactone, which parameter you must monitor after every few months? Hyperkalemia, gynecomastia, azotemia, alkalosis, hypernatremia. Which lab parameter you must look for? Yes, Rhoda Theza, yes star, Pooja A. Absolutely correct. Hyperkalemia because it is potassium sparing. Aldosterone secrete potassium in the urine. Aldosterone secrete potassium in the urine, and if you are blocking aldosterone antagonist, of course will cause hyperkalemia. But gynecomastia is also the side effect. Gynecomastia is the side effect, but you don't have to monitor for that. It is not, that dangerous. Hyperkalemia can kill the patient. Hyper and hypokalemia can kill the patient. Are you getting my point? Now, azotemia is like uremia, pre-renal, alkalosis, hypernatremia. So the only thing which you have to look for is hyperkalemia. It is the lab finding of uremia. Now, what is the diagnosis? A 25-year-old woman present to the physician with a complaint of vomiting for 3 days. Vomitus is watery, contain undigested food particle. He also complained of feeling tired, having sniffles, so does not like eating or drinking. Her concern is immediately get dizzy when she stand up. Pulse is this, the respiratory rate is low, BP is low. So what is the, before going to the values, tell me the diagnosis. Yes, it is metabolic something or respiratory something. What is the electrolyte electrolyte disturbance here? Metabolic, respiratory, or what? Of course, dehydration is there. Hypochloremic means increase in iron gap. Metabolic alkalosis. Okay. And is there any compensation? Can you see here, Theja? Can you see any compensation here? In the clinical finding, can you notice any compensation for metabolic alkalosis? Can you look for any type of compensation? Yes, very good. Yes, star. Good. Respiratory rate is low. Very good. Nice. So metabolic alkalosis with compensatory what? Compensatory respiratory acidosis. How you can say this? Because there is hypoventilation, there is carbon dioxide retention, there is hypoventilation, there is carbon dioxide retention. So now tell me the answer. Now you can tell easily the answer. Everything I have given. Alkalosis. So what is answer over here? B. In the B you are getting metabolic, are you getting acidosis or alkalosis? What is the final diagnosis? What is the final diagnosis? Yes, A. Final diagnosis is metabolic alkalosis 7.5. Bicarbonate normal 24. It is high 38. So metabolic alkalosis with respiratory acidosis. Metabolic alkalosis with compensatory respiratory acidosis. So answer is A. Isn't it an easy question? So this is how you can make this question. Now one more example I can take after that. Is this point clear? I can take one more example for this. Now what is your electrolyte imbalance over here? What is electrolyte imbalance over here? Metabolic 20-year-old girl just to see, I told you, whenever say metabolic acidosis, always say complete. Never say metabolic acidosis, always say high anion gap, normal anion gap. Always say, when say, never ever say metabolic acidosis. Never ever say metabolic acidosis. Always say, is it normal anion gap or is it increased anion gap? This is must. Sodium plus potassium 146 and 119. I think it's too high. 27. So how it is normal, Doda? I think it is high. I can see here. Metabolic acidosis is there, but it is a high anion gap. See, sodium is given, potassium is given, chloride and bicarbonate is given, and anion gap is coming 27 according to me. High because he took pills. No, high you can see from here now also, na? Why you are believing on her pills? Don't rely on the pills. Sodium plus potassium minus chloride plus bicarbonate, it is 27, not 16. Very, very high. So what are the cause of high anion gap? Mud piles. What are the cause of high anion gap? Mud piles. So can you see any mud pile? Can you see any mud over here? The example which I have given regarding mud piles. Just tell me which is the example. Acetaminophen, calcium, codeine, dipisate, furosemide. Which example we have discussed in high anion gap? Yes? Yes, acetaminophen, yes. Of course. The first example. So acetaminophen is the answer. Okay. One more question, similar question I will discuss. Okay, now which electrolyte abnormality is here in this case? Similar question. similar question, and this is sodium, this is potassium, this is chloride, and this is your bicarbonate, this is the pH. थोड़ा सा mismatch है, you can manage with this. What is the answer now? This is the last question of the day. After that I will say only best of luck, all the best. Very good, very good. So all answers are correct now. So it means everything is clear now. So what is the answer now? Now you can tell me the answer. A, B, C, D, E or F? Yes, D. Teja, can you see respiratory compensation here? How you can say there is compensated? Is there any finding here which you can believe that he is having compensation? Is there any, hyperventilation or hyperventilation can you see here? So answer is C or D. Some of you are saying D, some of you are saying C. Yes, no compensation. So what is the answer? Very good. So now everyone is with the answer C, non-anion gap. Just to tell you one more thing, normal anion gap is also called as non-anion gap metabolic acidosis. Okay. So if you want to do last question, okay, just I will take 2 minutes more. 2 minutes more. Just 2 minutes more for everyone. A 22-year-old female college student present to emergency department due to severe pain in stomach. The pain is located in the upper half of the abdomen, is severe intensity. She claims to have consumed dozen of alcoholic drink. A 22-year-old girl claiming to have consumed dozen of alcoholic drink. Her past medical is everything is okay. And also she is trying to lose her weight 10 kg. एक तरफ 10 kg वेट कम किया उसने और दूसरी तरफ डजन ऑफ अल्कोहल. हर पल्स इज 130, रेस्पिरेशन 26, बीपी इज नॉर्मल, विजिबली डिस्ट्रेस, यंग फीमेल, पेरी अम्बिलिकल टेंडरनेस. सी द लैब पैरामीटर एंड व्हाट इज द डायग्नोसिस? सी द लैब पैरामीटर. This is the last question. After that I will not take your time. This is the last variety of the question which we have done. respiratory acidosis, metabolic acidosis with partial respiratory compensation. Where there is metabolic acidosis, I think this is normal value. Kyli is correct. Respiratory alkalosis. So Kyli is correct. Respiratory alkalosis, of course. Now, what is the answer? What is the answer? Alcohol induced vomiting. So what will happen? What will happen if there is alcohol induced vomiting? What is point in that? What is point in that? Yes, anxiety. You cannot. Can you see 22-year-old female college, 22-year-old female college student, and having so many, a dozen of alcoholic drink after that, and don't you think that she is anxious? So when someone is anxious before the examination or whatever, there is hyperventilation, carbon dioxide wash out. Okay, there is carbon dioxide wash out. So there will be respiratory alkalosis. So answer will be D. This is the last variety which we can discuss regarding metabolic. So this is it for today. All the best for everyone. For any doubt, you are most welcome. Till then, bye bye. All the best.